All right, let's talk about tubal ligation. If you're considering permanent birth control, you may be heard of tubal ligation, getting your tubes tied, laparoscopic bilateral self-injectomy. What do all these terms mean, and how can we best navigate that conversation with your doctor to potentially get the form of birth control that you want or need? We're breaking it all down in this video. That includes the procedure, the recovery, how it works, myths. Stay tuned to the end of the video. We'll actually have some surgical video to show you what it's actually like in real person to perform the laparoscopic bilateral self-injectomy. So back to the video. So let's dive in. What is tubal ligation? So the procedure that we often do these days is what's called laparoscopic bilateral self-injectomy. This is not pregnancy related. So you can also do a tubal ligation at the time of a C-section or maybe even postpartum. But mainly we're going to be talking about laparoscopic bilateral self-injectomy. Patients coming to my office because they want a permanent form of birth control. So let's first talk about the procedure. So what is it? Well, we got our picture here of the uterus, which, again, it's a pear-shaped uterus, and the tubes come off the sides here and ovaries on each side. And so a tubal ligation is when we block or burn, cut, clip the tubes. Laparoscopic bilateral self-injectomy is when we remove the fallopian tubes entirely, and this is more commonly over the last 5 to 10 years, often thought of the best way to do it and the most common way to do it now. Tubal ligation is often an overarching term for the different ways to block or remove the fallopian tubes. And so this is done surgically. Now, it can be done at the time of a C-section, but mainly I'm going to be talking about getting this done not around the time of pregnancy, so we'd be doing the surgery laparoscopically. The surgery is done under general anesthesia, and so fully sleeping, fully comfortable during the procedure, and we make, once somebody is asleep, we clean the belly, we make a few little incisions on the belly. The belly gets inflated with gas, CO2 gas, so we can see during the procedure. We go in, we find the fallopian tubes, and often the most common way to do it these days is to actually remove the fallopian tubes completely. Now, often in the past, what they did is clip them or burn them, found out not to be as good or as effective. And with clipping, you're putting another foreign body or foreign object in the body, and so that just doesn't sound great anymore. And so actually found out that just removing the fallopian tubes likely has the best effect for prevention with less failures, but may even decrease a couple other issues that may develop, like potential cysts of the fallopian tube, potential cancers of the fallopian tube, maybe even of the ovary. It can help prevent some of those cancers, which is kind of a nice positive. We don't have as good of long-term data to fully understand the exact number and percentage decrease, but definitely some preliminary things are saying, okay, this might decrease the chances of fallopian tube or ovarian cancer in the future. So once we remove the fallopian tubes, we then take them out, and then we're pretty much done. We deflate the gas from in the belly, and we put little sutures in the skin, and they usually dissolve, and the bandage, and then it's done. 20 to 30 minutes. And then somebody's going home hopefully a couple hours later. Now, pain-wise after the surgery, as I've said in the past, pain reactions are very different. But generally someone could expect, maybe like a 4 out of 10, 5 out of 10 pain is what my patients say for this type of surgery. And not a lot of pain with just laying there, maybe moving around over the next week or two. Your doctor might give you specific restrictions as far as like when you can start doing all of your normal activity. For my patients, I usually have the discussion, well, I want you getting up, I want you moving, even that same day of surgery, every few hours, eating normally after surgery. You don't have a restriction on your diet. And as far as those real strenuous activities like lifting heavy, push-pulling, like a lot of the exercises beyond walking, often it's like a week. Some might say 2. But it's just as a precaution to make sure there's no issues with the healing during in your recovery. So let's go through a few different myths which I commonly hear out there and I commonly see online. Number one, that removing the fallopian tube will mess with the hormones or it will mess with the menstrual bleeding. Actually, it's false. It will not. The menstrual bleeding generally comes from the inside cavity here, and the part of the fallopian tube that is removed here doesn't give that menstruation, and so removing the fallopian tubes shouldn't affect somebody's bleeding. Now, there are a number of reasons that someone can have affected bleeding later on in life or their menstrual years, and so this should not affect that. As far as the hormones go, the fallopian tubes and ovaries, they are not dependent on each other. They might share a little bit of venous blood flow in the thin membrane called the mesosalpinx here between the ovary and the fallopian tube, but the ovary is not dependent on the fallopian tube, and so your ovaries are your big hormone producers through the menstrual years, and so generally are not affected by tubal ligation or removing the fallopian tubes. And that goes along with myth number 2 is that somebody may develop menopause earlier if they have this procedure done. Again, the hormones aren't significantly impacted by this procedure. Another myth out there is that it's reversible. While technically it could be reversed if somebody has the clips or if somebody potentially gets a portion of the fallopian tube burned. If someone has a laparoscopic bilateral salpingectomy, it is not reversible. But that kind of defeats the purpose of this type of procedure is that when we're having this conversation with patients in the clinic, it should be well understood it's not reversible. That is not the intent. While someone might make a decision in their 20s or 30s and potentially have a risk of regretting that later on, that is certainly true. There is a procedure we could surgically try to reapproximate the fallopian tube if it was clipped or burned. However, that procedure, 1, has a significant cost, 2, is not 100% effective or not even close, increases the chances of ectopic pregnancy, and so it's just not a good alternative. And so going into this procedure knowing it's not reversible is kind of the standard. And another myth is like how this might affect somebody's sex drive, thinking that if we remove the fallopian tubes, could it affect that? And no, it absolutely should not. Again, I think the thought is like it affects hormones and such, but it does not, and so it shouldn't have any impact on this. When it comes to this procedure, I know a lot of people have been not taken seriously, have been turned away because of potentially things like doctors saying they're not old enough, or doctors saying they haven't had enough kids, or there was even a thing where in the past certain states required you to have your spouse consent to get your tubes tied, which is crazy. And so rightfully so, a lot of people are apprehensive about these conversations. And so, let's go through, how the conversations generally should go when you're seeing your doctor about potentially getting your tubes tied. Hi, doctor. I've been wanting to get permanent birth control. I want to get my tubes tied. I've been thinking about this for a while, but I have a lot of questions. Welcome to our office today. Let's go over all the questions you have regarding this and give you some potential alternatives also. There are a lot of options when it comes to birth control and contraception, but I totally understand if you would want to get something permanent. Are there any better alternatives that I'm not thinking of? Now, certainly, there are other forms of birth control that are really effective. There are certain things like pills, which are effective if taken on a regular basis. However, can have potential side effects due to the hormones. There are patches, same idea. There's a vaginal ring, there's a shot. But some of the best options for people that are thinking they don't want pregnancy for years or may not want pregnancy at all is what we call LARC, or long-acting reversible contraception. These would be things like IUD. These would be things like the arm implant that have minimal hormones or no hormones and almost are just as effective as tubal ligation, what we're talking about now. But if those options just don't sound the best for you and you think the best decision is permanent contraception, I totally understand that. I just wanted to say those things just in case someone didn't know they were good options, or they heard myths or misconceptions about those options too. I know for sure that I don't want kids, or I don't want any more kids, and I want something permanent. And so I don't want to have to worry about the other options or taking a medication or potential side effects. Can you please tell me what the best option might be? If a permanent form of contraception sounds the best for you and you have a long-term partner, actually the best form is a vasectomy. It's less invasive. It's a quick in and out procedure where somebody doesn't have to undergo anesthesia and there's minimal soreness and the recovery would be much easier. So if you're with a partner that would be willing to do that, amazing. However, I do get patients that are seeing me that may not have that partner or someone that is unfortunately unwilling to do that. We'll make another video on vasectomy in the future. Oh, okay, that's great. No matter what, I still want to get my own tubes tied. And so, but I've heard a couple of things. Number one, could it potentially mess with my hormones or my periods, or maybe even make me go into early menopause? So overall, removing the fallopian tubes should not have any impact on your hormones. So things like sex drive, things like menstrual bleeding, things like early menopause shouldn't be a thing. And those are just myths. If I change my mind later, can this be reversed, or do I have to be 100% certain that I want this option? Well, the thing about tubal ligation, whether it's clipping, burning, or removing the fallopian tube, which we do most commonly called laparoscopic bilateral salpingectomy, is it's intended to be not reversible, meaning, we want patients to be so certain to the best of their ability that they don't desire pregnancy for the future, because reversing the tubal ligation is extremely difficult and impossible if we perform the laparoscopic bilateral salpingectomy. And so the thought is you should not choose this option if there is any thought or any part of you that maybe want it reversed in the future. Now, I do let you know that in certain points in life, thoughts on this could change. And so sometimes there is a risk of regret when somebody gets their tubes tied, that later on that they could regret it and wish they hadn't. Generally, that's for somebody that's a little bit younger, in their 20s. That risk of regret might be a little bit higher. But I trust that if you feel like you are making the best decision for you, how effective is it? Can I still get pregnant if I get this done? So as far as how effective it is, it's super effective. Can be statistically some failures with clipping, burning. Statistically, it's 99% effective. No method, unfortunately, is 100% effective. But there is a 1 in 200 risk of failure. Now, with the newer form of tying the tubes, or what's called laparoscopic bilateral salpingectomy, it's newer, so we don't quite have that long-term data on, is it better? But we certainly are seeing that it is. Me personally, I've never seen a pregnancy after removing the fallopian tubes. Again, can't say 100% effective with any of the options. Now, I've heard for some people and online that some doctors refuse to do this procedure for certain women if they may have not had children or not had enough kids, or they think aren't old enough. Is any truth to that? Yes, unfortunately, I have also heard that there are providers or doctors or surgeons out there that might refuse or make it harder for somebody to get this form of permanent birth control due to a number of different reasons. Some people have to go through that, and they lose trust, and they get nervous when they're coming in to see providers like me, thinking that we would just outright deny them, or just not even getting here to the appointment because they feel like they will be rejected. As far as what the state requires, in some states, and depending on the insurance, you might be required to sign a piece of paper that says you understand this is a permanent form of birth control, it can't be reversed, and that you understand that. And that's it. Now, often there can be some slight variations in age when it comes to how old or young somebody can be when they are allowed to get their tubal ligation. And for people with state insurance, if often 21 years, you have to be 21 years or older. In some states, it can be 18 or 19, depending on the state. But beyond the state requirement, there shouldn't be a restriction for each individual. You are an adult, you are able to make your own decisions. As far as the number of kids you need to have prior to getting your tubes tied, there is no restriction on that. If you've heard that, some providers saying that, that's incorrect, and that someone should seek a second opinion right away. Yes, in the past, there were certain states that required a spouse to also sign the paper for the woman to get their tubes tied. Luckily, that is the thing of the past, but there were states that did require that not too long ago. So a couple other points to talk about is that I think that, don't be offended if your doctor, if you're coming there to have the discussion about getting your tubes tied, talks to you about alternatives. It's our job to give you all the information. It's hard to know what someone's done as far as the research prior to saying they just want the laparoscopic bilateral salpingectomy or the tubal ligation done. So it's our job to give you all the information. Don't be offended if we start talking to you about things like IUD as alternatives. We're not trying to convince you. We're just trying to present all alternatives so somebody can make their best decision possible when it comes to their contraception. And so if someone, what I always do is present options, and then at the end of that conversation, if somebody's like, you know what, I still want to go proceed with the tubal ligation, perfect. But yes, so if you're not getting the potential answers, or if you're getting denied for some reason, please seek a second opinion. There is more than enough of us OBGYNs that are willing to listen to a patient and give them and allow them to make the best decisions for themselves regarding their own bodies and pregnancy desires going forward. We're on to now the surgical video. Now, unfortunately, the way we record these videos is on the computer here at the hospital, and it wouldn't transfer to my USB, unfortunately. But oh, look at that cute little appendix there. But yeah, so this is actually us. We have three 5mm laparoscopic ports in the belly. So we've inflated the belly with the CO2 gas. And I'm working with my assistant Liz, our PA Liz, who often is there with me in surgery. You can try and guess which instrument she's using, which one I'm using, but we have the camera in the middle in the 5mm umbilical or umbilicus port. And we're using our bipolar grasper here on the left that not only cauterizes, but it can then cut the tissue afterwards. And so you saw me kind of going like this with my grasper there, but often that's what I'm doing. There's this thin membrane there between the tube, which is on the top, and the ovary there, that's the big whitish, yellowish thing there. And I'm trying to get as close to the tube as possible. I want to kind of stay away from the ovary as much as possible, hopefully decrease the chances of disrupting any of the blood flow to that area, because obviously we want those hormones for a long time. And so working our way through that thin membrane called the mesosalpinx down to the uterus, you'll start to see that coming into picture there. You see a little vaporization from this tool there. We have actually something hooked up to one of the ports where it evacuates a lot of that vapor from the bipolar device. But due to the angle inside that I'm working on, spoiler, I'm working on the left here. Liz has a grasper on the right. And so due to the angles, I actually went to the uterine cornua portion where the tube is inserting to better get an angle to finish the salpingectomy on the right. And so we got the tube removed there. Liz grasped it there and is going to remove it through her 5mm port. And often these come out quite easily. And then we're ready to move on to the other side. So again, that's actually the cecum colon over there with appendix going down there, and the tube and ovary here on the left, which I'm going to grab. And we find a little present there. That's the fimbria, that yellow portion, which Liz just touched there and grabbed. And this is actually a peritubal cyst. So if you've ever seen this on an ultrasound report, just a fluid-filled cyst, a benign cyst that is attached often to a portion of the ovary slash more often the fallopian tube. And so they're kind of this dense fluid filled, as you see it kind of pop there, so it can be easier removed after. And so what I'm doing is then grabbing the mesosalpinx, again shimmying up away from the ovary to try and incorporate most of that ampulla portion of the fallopian tube, which is the fimbria portion, and then away from the ovary as before. And so I'm working my way down there. Again, you'll see me shimmy kind of up, and I keep trying to do it again, keeping the tube out of my grasper. But then, so I'm shimmying, oh, and then it's there. So we're removing the tube, so we just coagulate there, and then I'll do a little bit like a half cut, because once that ovary starts to drop, then it's much easier to get a good grasp along that clear mesosalpinx, which is the area just under where my graspers are. And so yeah, work our way to the uterine cornua again, trying to get as close to the tube as possible on the mesosalpinx, and then quick edit there because Liz had to take out her instrument. And going back, removing the remaining portion, and you'll see me come across the part that connects to the uterus there. And often I like to do a little double burn here. I'll burn with the tool, release, burn again. Again, everyone does it differently. One burn is perfectly fine, but every one of us sometimes has our own little quirks about us. And so, yeah, now I'm just gonna position this tube, take it from Liz so she can grasp it easier along the end there, so easily remove that tube out of her small little port there. And at this point, we're done. As you can see, minimal to no blood loss, so perfect. And so, yeah, we'll deflate the abdomen, get all the gas out, and then repair the incisions and bandage over top, and then the patient's hopefully ready to go home within an hour or two. Well, I hope you all enjoyed that video. If you have further questions, let me know in the comments. And there is a little button right there that says like, and another one there that says subscribe. Thank you, everyone. Hope you have a good day.